Hi guys, good morning. So today we are going to start with another unit, that is the bacteriology. So in this, first we are going to discuss about the Staphylococcus. So basically Staphylococcus, it is a gram-positive cocci which are arranged in a grape-like cluster. Clusters, and it is the most common cause of the suppression. And coming on to the morphology, so they are gram-positive cocci which are arranged in a grape-like structures these are non-motile, non-sporing and approximately 1 micrometer in diameter. Fine. So after this, let's discuss what all are the gram-positive bacteria and what all are the gram-negative bacteria. So starting with the gram-positive bacteria, in this, the gram staining, which gives the purple or the bluish color or the blue color, it is divided into two parts, in the cocci and in the bacilli. Cocci is again divided into two parts, the catalase positive, which are present in clusters, and the catalase negative, which are the bacteria which are present in the chain. So the bacteria which are present in the cluster, these are the Staphylococcus, while the bacteria which are present in the chains, these are the Streptococcus. So the Staphylococcus, these are the coagulase positive and the coagulase negative. The example of coagulase positive is the Staphylococcus aureus and Staphylococcus pyogenes, while the example of the coagulase negative are the Staphylococcus epidermis and Staphylococcus albus. Now after this, let's discuss some catalase negative which are present in the chains like the Streptococcus. So it is of three types: the green or the alpha hemolysis, the clear or the beta hemolysis, and there is no hemolysis. So in the green hemolysis, there is capsule present and there is no capsule present. Where there is a capsule present, example is the Streptococcus pneumoniae, while where there is no capsule present, there is optokin resistance, example is the Streptococcus viridans. Coming on to the second one, which is the clear or the beta hemolysis, it is divided into two parts. One is the bacitracin sensitive and the bacitracin resistance. So example of the bacitracin sensitive is group A Streptococcus pyogenes, while the example of the bacitracin resistance is group B Streptococcus. So this is all about the gram positive bacilli and cocci. Yes, and in the bacilli there are Clostridium, which are anaerobe, and Corynebacterium. So this is all about the gram positive. Now let's discuss gram negative algorithm, which all bacteria, bacilli are there in the gram negative. So the gram positive, they stain purple and blue, while gram negative, they stain pink color. So it is of three types. Gram negative, it is present in the form of cocci, it is present in the form of the cocobacilli, and it is present in the form of bacilli. So in the form of the cocci, it is of two types, the maltose fermenter and the maltose non-fermenter. So the example of maltose fermenter is your meningitis, Neisseria meningitis, while the example of your maltose non-fermenter is Neisseria gonorrhea. Example of the cocobacilli are H. influenza and Bartonella hensleyi or the Hensley. Fine. Now coming on to the bacilli, so there are two types of bacilli again as that of the cocci, the lactose fermenter and the lactose non-fermenter. While in the cocci there was the maltose fermenter and maltose non-fermenter, and in the bacilli there is lactose fermenter and lactose non-fermenter. So example of the lactose fermenter are the Klebsiella and the E. coli, while the lactose non-fermenter, it is divided into two parts, the oxidase positive and oxidase negative. The example of oxidase positive is Pseudomonas, while the example of oxidase negative is Shigella and Salmonella. So this is all about the gram positive and gram negative. They give pink color while they give purple or blue color. Now let's start with the Staphylococcus. So CONNS, which is the coagulase negative Staphylococcus, it is important points. These are the important points. So cons, which is known as the coagulase negative Staphylococcus, in which first is the Staphylococcus epidermis. So in this, the normal commensal of the skin epidermis, it involves the normal commensal of the skin epidermis, and it is associated with the interventions like the IV cannula, the CSF, shunts, prosthetic valve surgery, and it causes the early prosthetic valve endocarditis less than 1 year. After the Staphylococcus epidermis, second are the Staphylococcus saprophyticus or the saprophyticus. In this, the young female, they develop the UTI, the urinary tract infection, and the most common cause is most commonly GPC, which is the gram positive cocci involved is the Staphylococcus saprophyticus, while the young female develops the UTI. Most common cause is overall, which is due to E. coli. There is novobiocin resistance, which is the no zone of inhibition. So these points are important for your MCQ point of view. Now let's discuss the differences between the Staphylococcus aureus and Staphylococcus epidermidis. So in this, these are the tests like the coagulase test, the mannitol fermentation, heat stable nuclease, phenolphthalein phosphatase, beta hemolysis on blood agar, golden yellow pigment, and sensitive to lysostaphin. So these all tests, these are positive in Staphylococcus aureus, while these all tests are negative in Staphylococcus epidermidis. Fine. Now coming on to the starting with the Staphylococcus aureus. So the Staphylococcus aureus, it is gram positive cocci, it is catalase positive, coagulase negative, it is catalase positive, coagulase negative, and gram staining, it gives the violet grape like structures or the clusters. See, these give the violet grape like clusters. Coming on to the culture media. So in this, in the nutrient agar, it gives the golden yellow pigmentation in the nutrient agar, while in the blood agar it causes beta hemolysis. This portion is the beta hemolysis, which is a complete portion. This portion is the alpha or the partial hemolysis, and in this point you have seen nothing. So in the blood agar, it causes complete beta hemolysis, in which you can see the pin head size colonies. Fine. Important point is this, that in the culture media, the blood agar, it shows the pinhead size colonies. Coming on to the mannitol salt agar, it is the best selective media, important for your MCQ. And Ludlam's media and the salt milk agar, these are all the 5 culture medias. Now coming on to the virulence factor of the Staphylococcus aureus. So there are numerous virulence factors which are responsible for the pathogenicity of the Staphylococcus aureus, but the most consistent association is the production of the coagulase and to lesser extent the fermentation. Coagulase and fermentation of mannitol. Important. So the coagulase causes the activation of prothrombin and it leads to the fibrin formation around the bacteria, which protects the bacteria from phagocytosis. This line is important. That the coagulase, it causes activation of prothrombin. Fine. Now what all are the virulence factors? So in this, cell associated polymers, cell surface protein, extracellular enzymes and toxins. So in the first one, which is the cell associated polymers, there is teichoic acid, cell wall polysaccharide peptidoglycan, capsular polysaccharide. Cell surface protein are protein A and the clumping factors. The extracellular enzymes are coagulase, lipase, hyaluronidase and the staphylokinase. While the toxins are the cytolytic toxins are the alpha hemolysin, beta hemolysin, gamma hemolysin and delta hemolysin or the hemolysin. And also there is leukocidin, enterotoxins, TSST and the exfoliative toxin, which TSST is the toxic shock syndrome test. Fine. So after the virulence factor, let's discuss some important facts about the virulence factor which are important. Number one is the clumping factor. It is bound to the coagulase, which is responsible for the SCT, which is the slide coagulase test, and it is coagulase which is the free coagulase. It acts along with the coagulase reacting factor in plasma, CRF. A type of the coagulase has been identified, most human strains from coagulase A. The most constant association of the virulence is the production of the enzyme coagulase and to a lesser extent with the mannitol fermentation, as we have already discussed, the coagulation or the coagulase and the fermentation of mannitol. So the Staphylococcus aureus, they produce 5 cytolytic toxins. This one, cytolytic toxins, which are the alpha hemolysin and beta hemolysin, gamma hemolysin, delta hemolysin and leukosin. These are the 5 cytolytic toxins which consist of the 4 hemolysin, as we've already discussed, alpha, beta, gamma and delta, and one is the leukocidin. So the alpha hemolysin, it is the important hemolysin. So out of the 5 cytolytic toxin, the alpha hemolysin, it is the most important hemolysin, and the beta hemolysin, it is a sphingomyelinase. Beta is sphingomyelinase. So it exhibits a hot cold phenomena, the hemolysis being initiated at 37 degrees Celsius but becoming evident only after chilling. So the leukocidin, it is also called as the penton valetin toxin, and in this the Staphylococcus leukocidin and the gamma lysine, they have grouped as a synergohymentotropic toxins. So which are toxins? The Staphylococcal leukocidin and the gamma lysine. These both have grouped as the synergohymentotropic toxins. Now next is the important point, which is the TSST, toxic shock syndrome toxin, and the enterotoxin. These are the super antigens which are potent activators of the T lymphocytes and lead to an excessive and dysregulated immune response with release of the cytokinin 1, cytokines, interleukin 1 and interleukin 2, TNF alpha and IFN-Y. So in this, the enterotoxin, it is responsible for the food poisoning. So which toxin is responsible for the food poisoning? Your answer should be enterotoxin, the exfoliative epidermolytic toxin. Exfoliative is a epidermolytic toxin. So responsible for the staphylococcal scalded skin syndrome, which is 4 times S. It means the staphylococcal scalded skin syndrome. So the severe form of the 4 times S is known as the Ritter's disease. Ritter's disease. What is Ritter's disease? It is the severe form of the Staphylococcus scalded skin syndrome in the newborn, and the toxic epidermal necrolysis in the older patient. So the milder form are pemphigus neonatorum and bullous impetigo. Staphylococcus does not produce endotoxin. Important point. Endotoxin is produced by only gram-negative organisms. The only gram-positive organism secreting the endotoxin is Listeria. Very important point. So in this, the Staphylococcus does not produce endotoxin. Endotoxin are produced only by gram-negative organism. So the only gram-positive organism which is produced or secretes the endotoxin is Listeria. Now after this, coming on to the toxin mediated illness, in which first is the staphylococcal disease. So the staphylococcal infection, these are among the most common bacterial infection and range from the trivial to the fatal. They are characteristically localized pyogenic lesions in contrast to spreading nature of the streptococcal infection. So in this, the most common pyogenic staphylococcal infection, these are in the skin and the soft tissue, the folliculitis or the folliculitis or the boil, abscess, wound infection, carbuncle, impetigo, paronychia, less often cellulitis. So these are the pyogenic staphylococcus infection which are present on the skin and the soft tissue. Coming on to the musculoskeletal, it can be osteomyelitis, arthritis, bursitis and the myositis. Coming on to respiratory, there is tonsillitis, pharyngitis, sinusitis, otitis and the bronchopneumonia, lung abscess, empyema, rarely pneumonia. The CNS, abscess, meningitis, intracranial thrombophlebitis, and in the endovascular, bacteremia, septicemia, pyremia and endocarditis, while in the urinary there is staphylococci. These are uncommon in routine urinary tract infection, though they do not cause infection in the association with the local instrumentation, implants or the diabetes. Urinary isolates of the staphylococci are to be considered significant even with the low colony count, as they may be related to bacteremia. Fine. So there are 3 most common toxic mediated staphylococcal diseases: the food poisoning, toxic shock syndrome and the scalded skin syndrome. And the SSSS. Now coming on to the first disease, which is the Staphylococcus aureus, which causes the food poisoning. So in this, the Staphylococcus aureus food poisoning, it results from the inoculation of the toxin producing the S. aureus into the food by colonized food handlers. It is caused by preformed enterotoxin. It is caused by preformed enterotoxin. toxins, and this enterotoxin, these are heat stable and it is a super antigen like toxic shock syndrome. So 8 antigenic types of the enterotoxin are currently known as A, B, C1, C2, C3, D, E and H. These are the 8 types of enterotoxin. So in this type A, it is responsible for most of the cases of food poisoning. So the toxin stimulates the vagus nerve and the vomiting center in the brain. It acts directly on the autonomic nervous system rather than the gastrointestinal mucosa. Important point. So the toxin is antigenic and neutralized by the specific antitoxin. The enterotoxin, these are produced by the Staphylococcus aureus, grows on the carbohydrate and on the milk and on the protein foods. The staphylococcal food poisoning, these occur after eating meat, milk, fish or the milk product as the custards or the potato salad. Staphylococcus aureus food poisoning, it is characterized by the nausea, vomiting within 1 to 6 hours of the ingestion. Diarrhea, hypotension and dehydration may also occur. In this, fever is unusual. Diagnosis can be established by the demonstration of the bacteria and documentation of the enterotoxin. The staphylococcal food poisoning, it is self-limited illness. Symptoms generally resolve within 8 to 10 hours. Treatment is symptomatic. No antibiotic is required. Next is the toxic shock syndrome. So in the toxic shock syndrome, there are 2 types of syndromes, the staphylococcal TSS and the streptococcal. The staphylococcal toxic shock syndrome results from the elaboration of the toxic shock syndrome type 1. Type 1 toxic shock syndrome, and also known as enterotoxin type F and pyrogenic exotoxin C. Important. Enterotoxin B or C may also produce the toxic shock syndrome. Coming on to a streptococcal. Streptococcal toxic shock syndrome results from the elaboration of pyrogenic exotoxin A, C. The staphylococcal toxic shock syndrome, it results from the enterotoxin type F and pyrogenic exotoxin C, while streptococcus, it results from the elaboration of pyrogenic exotoxin A. Fine. So now let's discuss the laboratory diagnosis of the staphylococcal infection. So in this, the specimen, it basically depends upon the type of the lesion, the pus from the abscess, wounds or the burns, the midstream urine from the patient with the cystitis or the pyelonephritis, the sputum from the cases of pneumonia, while the feces or the vomit and the suspected food from the patient with the suspected food poisoning. Important. The blood from the patient with the suspected bacteremia, example the septic shock, osteomyelitis and endocarditis. Anterior nasal on the perineal swabs from the suspected carriers. Coming on to the smears. So typically, or the typical staphylococcal are the gram-positive cocci. These are arranged in a grape-like structure, violet in color. These are non-motile, non-sporing, and some fresh isolates show microscopically visible capsule. Culture diagnosis may readily be made by the culture. The specimen is on the blood agar. Fine. On the nutrient agar slope, it shows the oil paint appearance. The selective media is the ludlums, that is the lithium chloride and the telluride, the salt milk agar and the RCM, which is the Robertson cooked meat medium. So for the primary isolation, sheep blood agar, it is recommended. Important. Human blood should not be used because it contains the antibodies or other inhibitors. So in this, the Staphylococcus aureus, it gives the golden yellow colonies. The Staphylococcus albus, it gives the white colonies, while the Staphylococcus citrus, it gives the lemon yellow colonies. Important. Coming on to the catalase test. So the catalase test in the Staphylococcus aureus is positive. It is distinguishes from the streptococci. The coagulase test, it is performed to distinguish the Staphylococcus aureus from the coagulase negative Staphylococcus. So it is done by the two methods, the tube coagulase test, which is detect for the free coagulase, the slide coagulase test, which is detect the bound coagulase, which is a clumping factor. Now, what is the difference between the free coagulase and the bound coagulase? In the free coagulase, it is an enzyme which is secreted into the medium, while in the bound coagulase, it is a constituent of the cell surface. In the free coagulase, it acts with the CRF, which is the coagulase reacting factor, while in the bound coagulase, the action is independent of the coagulase reacting factors. So in the free coagulase, it is 8 types have been identified, in which A is the most common cause, while in the bound coagulase only one type has been identified. So after this, let's discuss the important biochemical reactions of the Staphylococcus aureus. So in this, the ferments mannitol, other Staphylococci do not ferment. Phosphatase positive useful screening procedure as the Staphylococcus epidermidis, it is negative or only weakly positive. It produces the golden yellow pigment, produce clear hemolysis on the blood agar, that is the beta hemolysis, which is complete, and alpha was partial. Catalase positive, unlike the streptococci, hydrolase urea, which is the urease positive. Important point to remember is the anti-staphylolysine antibody against the alpha lysine, titer of more than 2 units per ml, especially when the titer is rising, may be of value in the diagnosis of the deep-seated infections such as the bone abscesses. Now coming on to the very important topic, which is the MRSA, methicillin resistant Staphylococcus aureus. You can expect a number of questions from this. The MRSA is a bacterium which is responsible for the several difficult to treat the infections in the human. It may be referred to as multi-drug resistant Staphylococcus aureus or the oxacillin resistant Staphylococcus aureus, which is the ORSA. The MRSA is by definition any strain of Staphylococcus aureus that is resistant to the beta-lactams, including the penicillin, methicillin, cloxacillin, and nephcillin, oxacillin, and the cephalosporin. The resistance developed due to the alteration in the transpeptidase, which is penicillin binding protein. Transpeptidase, on which all the beta-lactam antibiotic acts. So the MRSA is resistant to all the beta-lactam antibody. The MRSA, especially community acquired, the MRSA CA, community acquired CA, displays enhanced virulence, spreading more rapidly and causing disease much more severe than that of the traditional Staphylococcus aureus. So in this, the MRSA, which is the community acquired, it spreads more rapidly than that of the traditional Staphylococcus aureus. So the vancomycin is the DOC for MRSA. Now next is the Staphylococcus saprophyticus. As we have already discussed, the Staphylococcus saprophyticus may be present on the normal human skin and the periurethral area and can cause the UTI. Particularly in the sexually active young women, the Staphylococcus saprophyticus stains causing UTI are usually sensitive to the antibiotic, except the nalidixic acid. The Staphylococcus saprophyticus is the novobiocin resistance. We have already discussed this at the beginning here. So coming on to the Staphylococcus epidermidis, so it is the most common coagulase negative Staphylococcus which causing the human infections. It is present on the normal human skin where it is most abundant bacterial species, as well as in the oropharynx and in the vagina. It is the most common cause of the stitch abscesses. It has a predilection for the growth on the implanted foreign bodies such as the artificial heart valves, the shunts, the intravascular catheters, and the prosthetic appliances, which leads to bacteremia. Important. The Staphylococcus epidermidis, it is uniquely adapted to colonize these devices by the capacity to elaborate the extracellular polysaccharide slime that facilitates the formation of a protective biofilm, the slime layer, on the device surface. So the surface associated with the staphylococcal enzyme is the autolysin ethyl. It may play a role in the attachment to the prosthetic surfaces, which are often coated with the host serum or the tissue constituents such as fibrinogen or nectin. So it can cause the cystitis and the endocarditis. Important. So next are the features for the distinguishing the major species of the Staphylococci. Number 1, coagulase. It is positive in aureus, negative in epidermidis, and negative in saprophyticus. While the novobison sensitive, it is the Staphylococcus aureus, it is sensitive. The epidermidis, it is also sensitive, while the saprophyticus, it is resistant. Acid from the mannitol anorbically, it is positive in the aureus, negative in the epidermidis, and negative in the saprophyticus. While the phosphatase, it is positive in the aureus and epidermidis, while it is negative in the saprophyticus. Now, lastly, these are the important points to be remembered. So in this, first is the infective endocarditis. It is an IV drug abusers commonly involves the tricuspid valve, and these are caused by Staphylococcus aureus in infective endocarditis. So the most common cause of the native valve endocarditis is the Staphylococcus aureus. The most common cause of the early onset prosthetic valve endocarditis, it is coagulase negative staphylococci. The most common cause of the late onset prosthetic valve endocarditis, it is streptococci, which is the Streptococcus viridans. The most common cause of the endocarditis in the IV drug abusers are this one, Staphylococcus aureus. The most common nosocomial infection is the urinary tract infection. Most common organism causing the nosocomial UTI is E. coli. The most common organism causing the early onset of the nosocomial pneumonia, pneumococci. So the most common organism causing the late onset nosocomial pneumonia are the Staphylococcus aureus, and the most common organism causing the surgical site of infection is the Staphylococcus aureus, while lastly the most common organism infecting burns are Pseudomonas. These are the very important points for your MCQ point of view. So guys, this is all about the Staphylococcus. Please go through it once and try to make the notes. Thank you.